Okay.
Thanks.
All right, we'll talk a little bit about occipital fixation, my disclosures. And so we'll start with a little history. We started with wires and then jumped down here. We played with buttons very shortly and hooks, but really it's all screws. But just for historical context, even before these loops made with the Bendmeister, we would wire just rods or bone to the occiput, and it could work. And here's these buttons, very stiff, very strong, very fussy to put in. And so this is a historical one. Do you ever put any of these in, Rick?
No.
And then the hooks. I mean, you can make a burr hole. You can put your hooks in. You can distract across them. And there was a brief kind of hook time when I had some interest in hooks, but that's all for historical perspective. Because as soon as screws came out, a number of biomechanical articles came out, and every single article that compared screw fixation to any other fixation found that the screw fixation was superior. So we're off and going. It's all screw fixation. And we have to think about where we're going to put the screws. So if we think about posterior occipital anatomy, we have superior nuchal line, inferior nuchal line, so these are good ridges of bone. You need to keep your instrumentation below that superior nuchal line because the musculature hooks on there. You start getting above that, there's no soft tissue coverage, and you're going to have to worry about erosion through the scalp. So first of all, you got to stay below it. The lower you get, the bone does get a little thinner, and also your angle to put the screw in starts to become compromised, and you have to start to use drills and screwdrivers with universal joints or flexible ones, which are inefficient. So the lower you go, the bone is worse. So if you can stay up near the nuchal line, near the midline where that good bony ridge is, that's ideal. And just looking at how thick it is, this is in the midline, at the external occipital protuberance, high in the midline, right at the nuchal line. Men have anywhere from 1 to 1.5 centimeters of fixation, women around 1. But you're usually not right in the midline. You're off to the side a little, and you generally have an average around 8 millimeters over 2 centimeters if you come down that center and you're centered. And 8 millimeters of fixation, especially if it's bicortical there, is outstanding fixation. In fact, the same theme that all happened as we were developing instrumentation screws, the biomechanical theme, we looked at screw pullouts, and one article, no difference between unicortical and bicortical, and a second one even went so far as to say the unicortical occipital screw was the strongest screw that we put in. It was stronger than pedicle screws. It was really a powerful screw. And then Rick knows, this is one of my favorite articles. Rick and Paul were looking at, they were interested in, as I read the article, they were interested in how rigid was the fixation to the skull. What did we do to, how many, did they put in plates, how did they hook the rod to the skull? And it seemed like that was the hypothesis, but what they found was, it didn't matter how they hooked it to the skull. The rigidity was completely related to the stiffness of the longitudinal member. So if they used a plate, it was the biggest, stiffest. The thicker the rod, the stiffer the segment. And so we learned from this that we want to use robust rods. And early on, here's a patient of mine, this is a 3.0 rod, and look what happens, it breaks. And so now, you should use at a minimum 3.5, or some systems will accept 4.0 rods. You can get a stiffer rod with cobalt chrome. So you want to put in the stoutest rod that you can. It'll help your fusion rates, it helps post-op pain, and you don't have to worry about hardware failure if your fusion's a little slow in developing. There are a variety of plate systems used, and I believe most people use plates. There's all sorts of nuances to them to make it easy to hook your rod up. Your subaxial screws should go in. Your rod should contour to your subaxial screws first. And then the posterior occiput's a huge target. You can then bend your rod in it, and it's easier to fit than to hit all your subaxial screws. And so keep that in mind. I am more a fan of this thing over here, although I like a closed one, because I feel that the plate limits some of my options, and it covers a lot of posterior occiput I want to use for grafting. And so here's one of my patients, and I just use these little, I call them buttons, and you can see how much they got big graft on either side of the rods. And so I shy away from the plates, but I realize they're pretty much probably what most people do. You want the screws in the midline. Maybe not exactly, but roughly. And you'd say, well, if I'm lateral, that'll help with axial rotation. But that's just not true, because axial rotation's at 1-2. So you're going to fuse 1-2, takes care of the axial rotation problem. There's no axial rotation between occiput and 1. So being a midline is biomechanically sound. The purchase is great. It's ideal if you can get a centimeter or more screw in. But if you can't and you go bicortical before then, it's going to be okay. And then you can attach the screws either to rods directly with these little buttons, or you can fix your keel plate and then attach the rods to the keel plate. And so keeping in mind, you have a big piece of bone midline, so if you're off to the side, you're going to angle toward that bone, and you're going to incrementally drill, palpate, drill till you're through. Now, despite the excellent bone, I'm going to show some cases where things went wrong. There can be fixation failure. You have to have proper alignment. You have to pay attention to your bone quality, and I already showed a hardware issue. But if we look at this patient, first of all, this patient was fused in extension. And so this is something you want to avoid. You got to spend a lot of time before you even start the case making sure you got the patient, they're not tilted to the side, they're not looking up, they're not looking, maybe down a little bit is okay. But the patient's fused in extension. This is the day of surgery, and this is the next day. And I just told you, these screws are strong, they're great. So why did this happen? Well, this was all surgeon error. This surgeon must have been concerned about the profile, so they burred away half of the skull so that their screws lay short. And you got like a 2 millimeter screw in a piece of occipital squame in a patient fused extension. So it's just not going to hold. And look at that big keel you have in the middle. Just totally missed this. If that screw would have been like this and the next one would have been like that, you would have got great bony purchase, and you just have to worry about post-op dysphagia because you fused them in extension, but you wouldn't have to worry about the screws coming out. And here's the opposite excuse. This is a patient operated on a prominent place in the East Coast, comes to see me. Look at this. They got screws in the transverse sinus, in the torcula, and they passed the nuchal line. And the patient came to see me because you could see this right through her scalp. Push her hair aside, there it was. So you don't want to be up this high. You don't need this kind of fixation. You're going to get good fixation. You want to stay down here. See this soft tissue coverage? You should stop here because you need all of this to cover up your hardware. If there's been a posterior craniectomy that's big, it can be challenging. And I was interested in this technique for a while, but this is really a hard technique to do. And the idea is you're gonna worm your screw down this diplo in the skull. And when we did the course in St. Louis, we had a stealth station there. And so I made this little video here, and you'll see if I can get it to play, how hard it is. This is wiggly, you're trying to get it in, you keep falling off, and it's really hard to thread your screw down that diplo. And so the real answer now is the condyle screw. The condyle screw can bail this out. And I think this diploic screw was never popular, and I don't think it needs to be used. And we can thank Juan Uribe for really doing a lot of work on the condyle screw. So here it is on a CT scan. It's a tough screw to put in because it's low, right? You know, the occiput comes down. It's kind of in this little valley there. There's some veins in the way. It can be hard to do. And this is the only procedure I use image guidance for. I don't use it for anything else, but you just don't know where you are because the hypoglossal canal is anterior in the condyle, so you got the 12th nerve. You got a lot of real estate here, and you have really limited views to kind of look at it and figure out where you really are. And so the entry point is, so you got to have something to start with. Even if you're using image guidance, you got to figure out where you're going to put your probe. So 4 to 5 millimeters lateral to the foramen magnum, just a millimeter above the O1 joint. And medially, it's a little more than 15 degrees, and you aim superior a little. Normally, it's about 2 centimeters, and the condyle's not that big. You could put a 4/0 screw in, but most procedures are done with a little bit smaller screw. And so here's a case, and it has advantages. It has a shorter lever arm. You can have so now I have more screw in the condyle. You're going to get more screw in the condyle than you are the occiput. There's a large, if there's no craniectomy, you've got a huge, all the posterior occipits available for grafting. If there's a big craniectomy, you don't have to worry about it. You're going to graft the joints, and you can get your fixation despite no occipital bone. I've never had an intracranial hemorrhage. They are reported. CSF leak's not a problem. If you get a little CSF when you drill your hole, it's clear CSF, no problem. I know I'm bicortical, nothing's bleeding, stops with the screw, it's fine. But this is a little safer for the hemorrhage, and it can work with the craniectomy. But the disadvantages are you do have critical structures at risk. You have the hypoglossal nerve. You're also in the vicinity of the jugular bulb, ICA, and the vertebral. The vertebral's always up there if you're at the craniovertebral junction posteriorly. And I do think it's more demanding. There is a venous plexus in there. It's just kind of a little crevasse you're working in. And although we have biomechanical data with acute quasi-static testing, the screw's not that big. It's 3.5 millimeters. It's long. And we really don't know. These aren't been around, and they're not popular enough that we have a large experience to say, you know, are any of those screws going to fracture? Are they really going to hold? What's going to happen other than, you know, the 20 reps I did in my cadaver lab, and then I tested it and said, okay, it's really strong. I like it. So we do need to work out the biomechanics a little more, but it is an excellent option. And for me, it's kind of like the pedicle, subaxial pedicle screw. And if there's a big craniectomy, if there's some problem, then this is something I would consider. Otherwise, the standard occipital fixation works very well. And now I want to make a plug for bone. I heard someone say, did you say you use allograft iliac crest, or you harvested?
Allograft iliac crest, yeah.
I'm a big fan of rib. And every year I tell you this, it has the perfect curve for OC fusion. It's easy to get right under the scapula. I can take out a piece of rib before anyone can get this exposed. I can take it out, close it, and the resident or fellow hasn't exposed for OC fusion. And it fits well, and we did a study. There's less morbidity than harvesting iliac crest. I started doing this in the days before screws with halos, wires and halos, and we put the halo vest on right after surgery with absorbable suture. It wasn't that uncomfortable. Pneumonia risk is not higher, so it's an excellent source of bone, and I highly recommend it. And so with that, I'll conclude. There's a lot of options to where to put your screws, how to do it. Think what's safest in your hands, and make it as rigid as you can. Thank you for your attention.
Great talk. With that rib, how do you attach the rib? How do you secure it?
I suture the rib. So I think you really need to decorticate the posterior occiput because it's hard to get yourself to fuse to that. So I do that, and so on here, so I have these things are all in the midline, and my rods are here, and here's a piece of rib. And so once I've got this in, I decorticate this down here, and then I split the rib. I split it down the middle with a sagittal saw, and then I nest it against there, and I tie it to my rod. So now it's not going to shift around, and it's locked into the rod, and it just lays right where I want it.
And do you have anything distally? Is it also tied distally? Because you have it tied next to the
Usually I can kind of jam it under the rod next to C2. If I can't, I'll tie it. If you tie it in two places, sometimes it kind of pulls it off the bone. So you kind of wedge it one place and tie it so it doesn't move laterally. I use it also for my 1-2s. I use it interlaminar. I use a little piece for that. So